Welcome to Grand Rounds. My name is Adi Talati. I'm one of the Grand Round directors, along with Drs. Alex Harris and Rebecca Muley. It's not on? Is that better? Wonderful. Thank you. I'm Adi Talati. I'm one of the Grand Rounds directors, along with Drs. Rebecca Muley and Alex Harris. Welcome. Next week's Grand Rounds will be presented by Dr. Catherine Scher, who is a professor of psychiatry and the founding director of the Center of Prolonged Grief at the Columbia University School of Social Work. The title of her talk is Treating Prolonged Grief Disorder, a Post-Loss Stress Disorder. Now, we're trying something new next week. Dr. Scher will be giving her presentation remotely. However, we will be Zooming the presentation here live. So we invite you to come down and watch it together as a community, and we'll have coffee and pastries regardless. All right? And a reminder, if you are participating by Zoom, you may ask questions at any time during the talk, and they'll be fed to us, and we'll ask them on your behalf. You don't need to wait till the end, and please use the Q&A feature rather than the chat feature for that purpose. Okay, so today's lecture is co-sponsored by the Office of Equity, Diversity, and Inclusion in honor of Hispanic Heritage Month. And to introduce today's speaker, I'd like to invite Dr. Tanisha Kearney-Ramos, who is herself an assistant professor of clinical neurobiology here, and also a member of the Office of Equity, Diversity, and Inclusion, to do the full honors of introducing the speaker.
Good morning, everyone. As mentioned, I'm a junior faculty in the Substance Use Division here, and I am also a staff member with the Office of Equity, Diversity, and Inclusion, OEDI. And we are very excited to host Dr. Regina Miranda as the OEDI Hispanic Heritage Month Grand Round speaker. Many of you may actually know her because she, in fact, did her postdoc here, or part of her postdoc here, with some of the folks that may actually be in the room. But for those of you who don't know Dr. Miranda, she is a professor of psychology at Hunter College, CUNY. She received her BA in psychology from Yale in '97 and her PhD in clinical psychology at NYU in 2004, before completing a postdoctoral fellowship here at Columbia in the Division of Child and Adolescent Psych. I believe she was here from 2004 to 2005, and then finally joining the psychology department at Hunter College in 2005, which is where she remains now. Dr. Miranda directs the Laboratory for the Study of Youth Cognition and Suicide, where her research focuses on understanding why young people think about and attempt suicide, using approaches that can inform assessment, treatment, and prevention of suicide risk. She also co-founded and directs the Youth Suicide Research Consortium, which seeks to increase diversity in youth suicide research. She has received many grants and honors for her efforts in this area, but notably, she has an impressive history of awards in mentorship, including a Science and Math Opportunities Network or Assignment Award for Outstanding Undergraduate Mentoring in the Sciences, which was in 2011. She has been also an Intensive Undergraduate Research Initiative Fellowship Mentor for many years, and was recognized as the Ad Council's Champion for Good in March 2022. And while all of those accomplishments are noteworthy in their own right, it is with pleasure that we also highlight the significance of her personal background and the relevance to this month's celebration of Hispanic heritage for National Hispanic Heritage Month. Dr. Miranda is a daughter of Honduran immigrants and a first-generation college student, and has personally experienced some of the challenges faced by many individuals from underrepresented backgrounds, and thus has worked her entire career to increase diversity in populations represented in mental health research. And this is also translated to a high quality in her mentorship, as is apparent by the many mentorship awards she's received. Please join me in welcoming Dr. Miranda as she shares some of her work in her talk today titled Understanding Youth Suicide Ideation, Role of Persistence, Form, and Content of Thinking.
Thank you so much for the introduction. I'm very excited to be here, a little nervous because of the live streaming, to be honest, not because of you. I was saying, I hope I don't go into a coughing fit at any point, not that I am sick or anything, because I don't want that out there for posterity. Okay, but I'm very excited to talk to you about understanding youth suicide ideation, the role of persistence, form, and content of thinking. I have no disclosures, relevant disclosures to report. These are the learning objectives of the talk. And just to give you an overview of what I'm going to talk about today, I'm going to talk a little bit about me and about my trajectory of my work, tell you a bit about my program of research, give you a flavor of some recent data from our lab, and then talk about future directions in our lab's work. Okay, so it is Hispanic Heritage Month, so I do want to honor my heritage. As Dr. Kearney Ramos mentioned, my family is from Honduras, so my parents are both Honduran immigrants. They were born in different parts of Honduras, and they met in Miami, although my mother spent some time in New York City. My father had a fourth grade education and became a crane mechanic. He spent some years in the U.S. Merchant Marine as a diesel mechanic, retired as a crane mechanic. And my mother was a teacher in Honduras who came to the U.S. first, landed in Astoria, Queens, and worked in a factory, took English classes, eventually worked in a bank, and when she retired, worked in a hospital in the housekeeping department, cleaning. My mother will be 90 in January, and my father turns 95 in December. And I'm the youngest of many half siblings. I'm the only daughter of both my parents. That's my family. And then I am a parent to two teenagers. My 14-year-old son is now the tallest in the family. He's getting close to 6 feet. And my daughter is 17 and will be applying to colleges this fall. So it is exciting, but also sad. And she wants to leave New York. And now I understand what it was like for my parents when I wanted to leave home. So just to tell you a little bit about my career trajectory, I went to Yale as an undergrad, where I worked with John Kihlstrom for my undergraduate honors thesis on research on mood and autobiographical memory. It was there that I became interested in the connection between cognition and emotion. And at the time, I was interested in studying youth depression and cognitive schemas in depression. And Dr. Kihlstrom was both a clinical psychologist and a cognitive psychologist. So he was a clinically trained cognitive psychologist. And I ended up at NYU, which in what used to be its clinical program, but now they no longer have a clinical program, working with Susan Anderson, who is a social personality psychologist who studies relationship schemas and the relational self. But the work that I primarily did with her was on trying to understand future-oriented schemas or future event schemas in depression. I never thought that I would do suicide research. Actually, at the time, I was a little bit scared of doing suicide research. But I did my internship here at Columbia at CHONY. And during that time, and I don't know if Laura's here. Laura was the internship director at the time, Laura Muffson. But I interviewed for the postdoc T32 at the end of my internship year. And back then, there was not a lot of research at Columbia on cognition and anything related to mental health that I remember, except maybe CBT treatment, but not looking at cognitive mechanisms. And so I think they were having a hard time finding where I might fit and who I might fit with. But I interviewed with David Schaffer, who at the time was the chair of the T32, and we had a conversation. Those of you who knew David Schaffer, that he was very intellectually curious, and we had a conversation about rumination, which was part of my area of interest. I started doing suicide research because he offered me an extra $20,000 on my postdoc salary, which back then was about maybe $35,000 a year. And so I'm like, yes, I will do 10 hours a week of suicide research. And little did I know that belief in me and that opportunity would lead to a 20-year career, so and counting, doing youth suicide research. So I'm very thankful to David Schaffer for the opportunity. I started at Hunter College in 2005 as an assistant professor, and a big surprise today, Dr. Gordon Barr is here, who was the deputy chair at the time, chair of the search committee, who hired me at Hunter and then later became our chair there when Vita Rabinowitz stepped down. I started there as an assistant professor in 2005. Now I'm a full professor, and I direct the laboratory for the study of youth cognition and suicide. And during my time there, I've been involved in different types of leadership, specifically related to increasing the representation of the US biomedical workforce. So I have in the past directed programs to increase the diversity of students going into PhD programs in biomedical areas. I was the co-director of the BP Endure program, which was a neuroscience program for undergrads. I think some of you, Jeremy, when you were at Vanderbilt, would have mentored some of our students, our BP Endure students. And I also co-directed the RISE program, which if those of you who are familiar with the IMSD program, the RISE program is like IMSD, but for lower resource institutions. I also served as deputy chair of our department, and I'm currently acting deputy chair because our regular deputy chair is on sabbatical, but it's only for this year. Recently became in 2021, one of the directors of clinical training of our doctoral program in health psychology and clinical science at the CUNY Graduate Center, which is a program that's only about 11 years old, but we received our first 10-year accreditation by the American Psychological Association last year. So and if anyone is interested in clinical psych programs, I'm not recruiting students for my lab this year, but we have a really great clinical science, a health-oriented doctoral program. Okay, so what about youth suicide? We know from decades of research that suicidal thoughts and behavior are relatively common among young people. They've been increasing over the past few decades, and that there are disparities. So the year that I started doing youth suicide research was around the time that we were starting to see increases in youth suicide in the United States after seeing decreases. And those increases have been rather steady, except for there was been decreases in the past year. So if you just look at the data from the World Health Organization, we've seen increases, especially among young adults. If you look at these data from the Youth Risk Behavior Survey, we can see disparities. So we've had in a decade increases among Black in suicide ideation, among Black, Hispanic, and white teens, and among Black and white teens in suicide attempts, except for 2023 when we saw decreases across various groups. And then if we look at sexual and gender minorities, we know that teens who identify, or young people who identify as lesbian, gay, bisexual, transgender, or queer, have among the highest rates of suicide ideation and attempts, even more so for queer youth of color. So there are different ways that we've sought to make a contribution in this area. One has been through research, which is what I'll spend a good chunk of time talking about. But I want to also talk about how we've tried to make a difference, or I've tried to make a difference through training and diversity efforts. And I want to highlight work training the next generation of scientists in this area. And if anyone's watching online from the lab, if you're not on the slide, it's not because you're not important, but I just can't fit everybody, all 160 people who've been through the lab. But this is some work of folks who started off as graduate students, whether master's or doctorate or even postdoctorate in the lab, and who developed their own areas of research and who are now independent researchers in their own ways. And so on the left, we've got Dr. Julilis Gomez. And then in the middle, toward the middle, you have Dr. Lilian Polanco Roman, who is a collaborator of several folks here and who's been through Columbia T32. She started off as a master's student at Hunter. Dr. Ana Ortin Peralta, who collaborated with Dr. David Schaffer and I when she was a Koplowitz Fellow and doing her doctorate, and who's worked with Cristiane Duarte as well, and who is a professor, an assistant professor at Yeshiva and Einstein. Jorge Valderrama, who's a consultant, who consults with an organization that works with the CDC on suicide prevention. Natalia Macro-Nicola, who is a postdoc at Harvard and works at Morningside, and recently graduated Dr. Beverlyn Rosario Williams, who is a postdoc at Johns Hopkins. And a lot of times people think that I am an expert on culturally related factors that are relevant to diverse youth. And the reason that they think that is not because I am, because I'm not. I would say that my expertise is really in cognition and youth suicide, but that there have been students and trainees that have come to my lab that have taught me about culturally related risk and protective factors for youth suicide. One of those being Dr. Judelis Gomez, who initiated that line of research in my lab that then others like Lillian Polanco-Roman were able to continue. And now Lillian is a superstar expert on the role of racial trauma in youth suicide. And she's currently serving out her sabbatical as a Radcliffe Fellow. And then these are some of my current PhD students. Sarah Sullivan on the left, who is doing research on suicide-related disclosure and recently found that among teens who disclose their suicidal ideation or attempts before being brought to the emergency room, to others, those who perceive the recipients of that disclosure as having been supportive are less likely to attempt suicide over 12 months than those who perceive the disclosure as having been responded to non-supportively. She's also doing formative work to develop a single session intervention to administer in the emergency department during that wait time when there's not a lot that kids are getting, especially in lower resource public hospitals. Felix Yerdong, who is a former student of Lillian's actually at the new school and who is doing work to understand when social support and social integration exacerbates risk versus buffers against risk for youth suicidal behavior. Lucy Liotta, who is looking at future-oriented cognition and is also interested in co-rumination and social support among queer youth and queer youth of color also. And then finally, an incoming doctoral student, former lab manager, Erica Rodriguez, who is interested in looking at different pathways of suicide risk, of imminent risk for suicidal behavior, and is also interested in multiply marginalized youth, including Black, Latina youth at risk for suicidal behavior. If you want to know the actual very interesting work that's being done in my lab, it's being done by these people. So I would invite you to invite my lab and my doctoral students to come do grand rounds, because I think you'll find their work a lot more exciting than my work. But I don't feel equipped I don't like to talk about other people's work, so I won't be talking about their work. But they do very interesting research, and you're stuck with the stuff that comes from my mind and goes out, not the stuff that comes from their minds. Okay. Another way that I've sought to make a difference in this space is through trying to change the field. And so in 2019, some colleagues and I launched the Youth Suicide Research Consortium, which is a network of youth suicide researchers that seeks to increase diversity in youth suicide research, provide support, collaborations, mentorship to early career researchers. And in just 5 short years, we have published the Handbook of Youth Suicide Prevention, which was the first youth suicide handbook that highlights underrepresented populations, written primarily by early career researchers and their collaborators. We've had 5 virtual conferences, and we have 79 members and counting. And we're always looking to increase our impact on the field. So we have lofty goals. We are an unfunded organization, and so we do this via the generosity of the folks who are part of the consortium who are involved, including our steering committee, Dr. Guerra Alvarez, who is an assistant professor at Johns Hopkins, Ellen G. Denton, who is an associate clinical professor at the University of Rochester Medical Center, and I believe she's collaborated with folks here. Actually, there's a whole line of research at Columbia on suicide prevention or suicide in Guyana, and LNG actually established the infrastructure that allowed that research to happen, so that it wouldn't have happened without LNG. Dr. Cassie Glenn from Old Dominion University, and of course, Carolina Hausman-Stabil, who works for the city of Philadelphia. So that is our hardworking steering committee. So moving on to the way that I've sought to make an impact through my research. So my program of research really has sought to understand the why young people think about and attempt suicide, so what they're actually thinking about when they're thinking about suicide, which I published on and we're working on now, but I won't talk about as much today. And then how young people think about killing themselves matters for prediction of risk. And so one way that we've sought to do this is by trying to understand the content and form of thought. So the content of future-oriented thought, the persistence of future-oriented thought, and the persistence of suicidal thought. So first, I want to start with some ruminative thoughts. So those of you who are familiar, and I talked about my conversation with David Schaffer on rumination. So I started off doing research on rumination, which, as defined by Susan Nolan-Hoeksema, is a cognitive process that involves a tendency to focus on one's depressive symptoms or one's negative mood and on the causes, meanings, and consequences of that negative mood or that depression. And so through some work in our lab, we sought to understand different forms of rumination that might be differentially associated with risk for suicidal thoughts and behaviors, and ruminative subtypes. And so Nolan-Hoeksema and colleagues identified two different ruminative subtypes, one called brooding, which is a tendency to dwell on a negative mood, which is thought to be the more maladaptive form of rumination. And we found in our research that it was also associated with suicide ideation via depressive symptoms. But then there was this other form of, I should say reflection, not refection, another form of ruminative thinking called reflection, which is more trying to understand why one is feeling the way that one is feeling. And that was always thought to be the more adaptive or neutral or benign form of rumination. And so we in our research, we found that reflection was also associated with suicidal ideation over time, but not via depressive symptoms, and that it depended. So for those in a study led by Katie Surrance, who actually also did some research here in the past at PI, those without a suicide attempt history did not show this relationship, but young adults with a suicide attempt history, there was a positive relationship between even this more benign, thought to be more benign form of rumination and suicide ideation. And we also found that it depended on degree of problem solving. So those who were low in active coping, there was a higher relationship between reflective rumination and depressive symptoms. And also prospectively, we found that reflective rumination was associated with suicide ideation over 18 months for those who weren't as good at problem solving, but not among those who were high in problem solving. We've also sought to understand the relationship between hopelessness and suicide ideation, and specifically components of hopelessness-related cognition that might predict suicide ideation. We've also sought to understand how hopelessness, which is a commonly studied predictor of suicide ideation and attempts, might be acquired via future-oriented repetitive thinking or rumination about the future. We don't call it rumination about the future because a reviewer didn't like that because it was too much like the other rumination. So we call it, now I have to say a lot more words, future-oriented repetitive thought. But in my heart, it's called rumination about the future. And also how it might be acquired through mental rehearsal or practice. So a long time ago, Susan Anderson conceptualized hopelessness in the form of depressive predictive certainty. So as conceptualized by Abramson, Seligman et al., hopelessness is thought of as a tendency to anticipate aversive outcomes in an absence of positive outcomes and to feel helpless about doing anything about it. And so Anderson and colleagues tried to operationalize this a little bit more specifically in the form of depressive predictive certainty, which was the point at which people expected with 100% certainty that bad things would happen in their futures and that there would be an absence of positive outcomes, that good things would not happen in their futures. And so in some work, we found that there was a concurrent relationship and a prospective relationship between that tendency to anticipate with 100% certainty that bad things would happen or good things would not happen in one's future, and suicide ideation, and tried to parse out, is it really expecting bad things to happen or an absence of good things in the future that is more uniquely associated with suicide ideation? And what we found was that adjusting for other covariates, that it was really certainty about an absence of positive future outcomes, that unique part of hopelessness that was associated with suicide ideation, all other things considered, was not so much expecting bad things to happen and being certain about it, but expecting good things not to happen. So kind of not seeing that light at the end of the tunnel is another way that you could think about it. And this is just an example, a table from a study, from a longitudinal study of 354 Young adults oversampled for history of suicide ideation attempt and followed up various times, 4 times over an 18-month follow-up period. And if you look above, you can see that this is certainty in an absence of positive future outcomes being uniquely associated with suicide ideation over an 18-month follow-up period. Okay, so establishing that relationship, we were also interested in trying to understand how do people acquire those anticipations and that certainty about an absence of positive or presence of negative future outcomes. And we thought, well, then one way might be through pessimistic oriented repetitive thinking, through rumination about the future, through repeatedly considering whether good things will happen to you or bad things won't happen to you. So just drawing on various cognitive models or cognitive theories, basic cognitive theories, the more that you mentally rehearse something, the more you might acquire a cognitive fluency in engaging in that procedure, right? And so then that may lead you to be certain about those things that you're anticipating because that fluency gets misattributed to increased certainty. So we wanted to see whether pessimistic repetitive thinking would lead to depressive symptoms and suicide ideation via cognitive fluency, and whether cognitive fluency would lead to being 100% certain or completely certain that bad outcomes would happen or good outcomes would not happen, and that would predict depressive symptoms and suicide ideation. So, in terms of causality, it's hard to do that without an experimental design, but it's not really ethical to have people mentally rehearse pessimistic future anticipations, especially those who might be highly symptomatic. So instead, we developed a measure of pessimistic-oriented repetitive thinking, the future-oriented repetitive thought scale, which captures the tendency to consider whether good things or bad things will happen in one's future. And the scale has 3 subscales, factors. So the pessimistic future-oriented scale it includes items such as, I think about the possibility of losing people or things that are important to me. I spend some time thinking about bad things that could happen. And people are asked to indicate with what frequency they think these types of thoughts. Okay, and what we initially found in a psychometric paper was that future-oriented repetitive thinking was distinct from self-oriented rumination and worry. It was associated concurrently with symptoms of depression and generalized anxiety disorder, and it distinguished among young adults with and without suicide ideation or attempts. And then we later found that it indirectly predicted suicide ideation over time. And so in testing the model, what we did was, this is again a sample of 354 young adults oversampled for a history of suicide ideation and attempts. And at baseline, they completed this measure of pessimistic-oriented repetitive thinking. They came back to the lab 2 to 4 weeks later. This was the days when we did everything in person, so no MTurk here or online studies. This was all done in person. And so they did a future event fluency task, McLeod and colleagues' future event fluency task, where they're given a minute to generate all the positive and negative things that could happen in the next week, in the next year, and in the next 5 years, separately for positive and negative. And so how many they generate is a count of fluency. And then they came back at 6 months and completed a measure of depressive predictive certainty, also depressive symptoms and suicide ideation. And what we found was that pessimistic future-oriented repetitive thinking indirectly predicted depressive symptoms and ideation through not negative future event fluency, but through an absence of positive future event fluency. So being less able to generate those positive future outcomes that might happen in the future. And that was associated at a 6-month follow-up with being more certain when anticipating that bad things would happen or good things would not happen in their futures. So the implications here are that future-oriented repetitive thought may be one way that people develop pessimistic future event schemas. So that might be an important treatment target. And if mental rehearsal or repetitively thinking about these future anticipations might be one way that people acquire these schemas, might it also be a way to modify those schemas? So might mental rehearsal be a way of modifying these pessimistic future event schemas that may lead to depressive symptoms and suicide ideation? So we sought to test that. We sought to test whether practice in making optimistic future event predictions would lead to decreased depressive predictive certainty and decreased hopelessness over time. And so this was a paradigm where we randomly assigned participants with low, mild, or high symptoms of depression to an induced optimism condition and to a control condition. And what we did was we manipulated, we had them look at given events on a computer screen that might happen to them, but to engage in two different mental procedures. So they looked at an equal number of positive and negatively valenced future events. But in one condition, in the control condition, they were asked to consider whether the event in front of them, the phrase in front of them, contained an adjective, and to make a yes/no decision about it. In our experimental condition, we asked them to consider whether this was likely to happen to them in the future and make a yes/no decision. So you're engaging in the same physical procedure, but the mental procedure that you're engaging in is different. And the way that we pre-configured it so that they would make optimistic predictions is so that the positively valenced events that they viewed were those that would have a high likelihood of occurrence. So for example, having dinner with a good friend, and you would have few highly unlikely positive events, and kind of an equal number of moderately likely events of each valence, so that they didn't know that that's what they weren't told, oh, think optimistically. It was manipulated so that they were engaging in the mental procedure of saying, yes, positive things are going to happen in your future, and no, negative things will not happen in your future. Whereas in the control condition, they're saying yes and no to whether a given phrase contains an adjective. So just to concretize this a bit more, they would see this prompt: is this likely to happen to you? Have dinner with a good friend. Respond as quickly and as accurately as possible. Yes, no. Contains it versus contains an adjective. Yes, no. Right? Can you tell the adjective? Right? Bad. Anyway. Okay. And so what we found was that practice in making optimistic predictions led to decreases in depressive predictive certainty, but only among those who had high symptoms of depression and not among those with low symptoms of depression relative to the control condition. And then we recently replicated this, well, a little while ago, not that recently, so that was over at one time period. And we also found that there were no changes in mood. So we wanted to see, okay, well, what if we increased it in frequency? What if we had people do this over a 3-week follow-up period, once a week over 3 weeks? And so we had a group of young adults without a suicide ideation or attempt history, and a group of young adults with a history of suicide ideation or attempts. And what we found was that practice also, regardless of grouping, led to decreases in hopelessness over time. This time we looked at hopelessness using a modified version of the Beck hopelessness scale, where we changed it from a binary response to a Likert scale. So led to decreases in depressive predictive certainty over time relative to the control condition. But as you can see, in the suicide related risk group, the control condition actually was didn't show any decrease relative to the, so it might be more impactful among those with a suicide ideation or attempt history. Okay, so in summary, we found that induced optimism was associated with decreased certainty when making pessimistic anticipations about the future, but only among those with depressive symptoms. It also decreased hopelessness over 3 sessions, regardless of suicide ideation or attempt history, but didn't improve mood. And that might be because this was not an acutely suicidal sample. These were not acute samples. And also, they were engaging in mental rehearsal, but not mental simulation. And there has been considerable research suggesting that mental simulation is actually associated with more changes in mood than simply mental rehearsal. Okay, so just to recap, certainty about an absence of positive outcomes independently and uniquely is associated with suicide ideation severity. Pessimistic, future-oriented repetitive thinking is associated with suicide ideation indirectly through reduced positive future event fluency and depressive predictive certainty, and induced optimism may be one way of changing pessimistic future event schemas. So this is all couched in a program of research that I mentioned, tries to address why young people think about suicide, what they think about when they think about it, whether how they think about it matters, and how we might change some of those cognitions that lead to suicide ideation and risk of attempts. And so I've talked a little bit about the why. I've talked a little bit about maybe how to change. I'm not going to talk about the what. but I'm going to spend the rest of my time talking about how young people think about suicide matters. We know that adolescent suicide is very difficult to predict, and there are many reasons for that. Often the teens or the youth who are most at risk may deny their suicide ideation for various reasons. So as a result, our field over the past few decades has tried to harness technology, advances in technology, to circumvent face-to-face inquiry. And I think that's important because we need to have an all-hands-on-deck approach. But there are also challenges that this presents, right? So if we're going to use ecological momentary assessment to follow teens over 30 days to ask them about their suicide ideation, they have to be willing to be followed up and monitored. If we're going to use passive monitoring, do a Fitbit or some other device, they have to be willing to give us their data. And if we're going to use artificial intelligence and machine learning to predict, we want to make sure that the predictions that we make are not biased against people of color, which we found is one of the challenges of using big data approaches to predicting suicide risk. So the basic premise of some of our research is that there's actually great value in asking adolescents detailed questions about their suicide ideation, and our failure to do so over the past 2 decades has been a missed opportunity. So we're old school in our lab. We're not so fancy. Maybe we'll get fancier in the future. I think we'll have to be, but we're focused on talking to teens with lived experience about their suicide ideation and using that information to improve prediction and measurement. So we've been focused on when adolescents think about killing themselves, what they're actually thinking and how they're thinking it. And suicide models tell us a little bit about why this might be important. So some of you may be familiar with these theories of suicide. The interpersonal theory of suicide looks at risk for suicide as a function of acquired capability and suicidal desire. And acquired capability is usually thought of as is measured by things such as your history of self-harm, how many suicide attempts you've made in the past, experience with painful and provocative events that habituate the person to self-harm and suicide. But actually, the model would also propose that one way that people can acquire the capability for suicide is by continually thinking about suicide ideation, mental rehearsal, mental elaboration. But that has received very little attention in the literature. The fluid vulnerability theory, which looks at risk for suicide as a function of chronic and acute risk, would suggest that there is underlying chronic risk that comes from continually thinking about suicide. Because the more someone thinks about suicide, the more that activates a suicidal mode, using kind of Beck's terminology of suicide thinking and feeling, and all of those connections and memory get strengthened. And the more you're activating a suicidal schema, the lower the threshold it takes to activate a future suicidal episode. So the less it takes to trigger a future suicidal episode. And then finally, we draw on the cognitive model, Wenzel and Beck's cognitive model, which would suggest that when a suicide-related schema is activated, a person may bias their attention to suicide-related information, and they may fixate on that. And if they can't disengage from that, they may reach a threshold of tolerance that would lead them to eventually go from thinking about suicide to attempting suicide. So what these theories would suggest is that how people think about killing themselves matters. And it matters based on these models because it's possible that the more a person thinks about killing themselves, the stronger their suicide-related schemas become, and the lower the threshold for activating a future suicidal episode, thus increasing their acquired capability for suicide. And there's some evidence from the youth and adult literature that suggests that this might be the case. So we published a study back in 2014 with David Schaffer that found that teens who participated in the Columbia Teen Screen Study, a suicide screen study, who ideated an hour or greater, had higher odds of attempting suicide over time and a shorter time to attempt over a 4 to 6 year follow-up period. A study by Sis and King that followed up teens over a year after they were discharged from hospitalization found that there were different trajectories of ideation, but the persistently elevated one was associated with the higher odds of an attempt and rehospitalization. And then ecological momentary assessment research by Evan Kleiman and colleagues with adults has found that different phenotypes of suicide ideation, and that persistently elevated phenotype was associated with a recent history of a suicide attempt, but did not look at teens and did not predict prospectively. So that study that I mentioned that we did with David Schaffer, we looked at characteristics in a community sample like timing of teens' most recent attempt, frequency of their, timing of their most recent ideation, frequency, wish to die during their most recent ideation episode, and ideation length, and adjusting for all of these characteristics and BDI, suicide attempt history, sex. We found that ideating for an hour or longer during their most recent suicide ideation episode was associated with over 3 times higher odds of attempting suicide over a 4 to 6 year follow-up period, and with a shorter time to an attempt. So I'll repeat that form of ideation matters, but assessments don't address form and pattern of suicide ideation. So in work that I started with with David Schaffer, we developed what I believe is the most comprehensive interview of adolescent suicide ideation that currently exists. You can go to the Center for Open Science and get it for free. Just some people who worked on this, especially Ana Peralta, who is still a present collaborator. And we started off by interviewing teens, and it was kind of like, okay, there's no interview that we have for a guide, so let's interview teens about their suicide ideation. We did some pilot research, and what we thought might be happening based on some pilot research was that on the day that a teenager would think about or attempt suicide, they experienced a mood-changing stressor. So maybe they had an argument with a parent, or they found out that they weren't going to graduate that year with their class. Something that changed their mood. And then there might be other events that would happen during the day. But at some point during the day, there was a triggering event, a trigger event or a precipitating event that proximately led to them thinking about suicide. So in the morning, you had a fight with mom, but that afternoon, you found out that you had a bad grade. And then, or there was a slight, an interpersonal slight that you experienced, and that led them to think about killing themselves. Because a lot of the precipitants that teens reported in our studies were interpersonal. And so as we continued interviewing teens, so we interviewed teens, we had a pilot sample of like 40-something teens, and then we collected another pilot sample of 68 teens, and we were trying to understand the precipitants of suicide ideation. And we were having trouble classifying based on this model, because we were finding that there was a small group of teens that we couldn't find the precipitants of their ideation. And I remember being in that back office on the second floor with Ana Peralta. We're like, okay, what about, and like, oh, light bulb, cognitive model, schemas, chronically activated schemas. And we realized, okay, that there might be different forms of ideation that are reflective of different underlying schemas. And there might be some teens who have a more chronically activated suicide-related schema that it doesn't take much to trigger their suicide ideation. They have no precipitant. And so what we, over time, we've continued doing this research in my lab at Hunter. And so we've been looking at 3 different classifications of teen suicide ideation. We were doing qualitative research without knowing we were doing qualitative research. I'm a quantitative researcher. I still have trouble understanding qualitative research, but I think we were kind of doing, a version of an uneducated person's version of like qualitative research. We noticed these 3 different subtypes of suicide ideation. What I was talking about before, which was brief suicide ideation. And so an example would be, an adolescent who has an argument with a parent, makes them sad and angry. They start to wonder why they were born and think their family would be better off without them. And then they maybe only thought about suicide that day and maybe another time during that previous 2 weeks. The ones that we were having trouble classifying initially are those with persistent suicide ideation. So it's a period of uninterrupted suicide ideation where we kind of set an arbitrary cutoff of 2 weeks or longer. They think about suicide every day for 2 weeks or longer. And what that might look like is an adolescent waking up, thinking about killing themselves, having suicide ideation throughout the day. Later, they see a drugstore and think about buying pills to take an overdose. And they've been thinking about suicide every day for the past 2 weeks or more. And then there was this group in between that didn't quite fit either of the above 2 subtypes, which were those with intermittent suicide ideation, where it was similar to persistent ideation, but it was really it was interrupted on and off. So maybe a teen who thinks about killing themselves on days that they're in school because they experience bullying in school, but not on days when they're not in school. And so we had this calendar. We asked them questions about their experiences of uninterrupted ideation in the previous month, but we also had this calendar where we have them mark off in the past month on how many days they thought about killing themselves. And so this is what a brief suicide ideation episode might look like, an intermittent episode might look like, and then a persistent suicide ideation episode. Okay, so the question we asked ourselves based on theory, can knowing the form of an adolescent suicide ideation help predict increased risk of a future suicide attempt? And we hypothesized that persistent ideation, because of this chronically activated underlying schema that lowered the threshold, that then it took less to activate a future suicidal episode, persistent ideation would be associated with greater attention fixation to suicide, again, based on the Wenzel and Beck model, and increased risk of a future suicide attempt compared to other forms of ideation. So we wanted to test whether persistent ideation would be associated with greater attention fixation to suicide, increased risk of an attempt, but also a shorter time to an attempt. And we did so via a study funded by NIMH through a SCORE grant, actually NIGMS via NIMH. We recruited 131 teens, initially 152, but only 131 were retained in follow-up, ages 12 to 19. Who presented to the emergency department or to outpatient clinics in the Bronx and in Manhattan with suicide ideation or an attempt in the previous 2 weeks. The teens had to be English speaking and parents could be English or Spanish speaking. And at baseline, we administered the adolescent suicide ideation interview, which allowed us to subtype their ideation, the attention fixation on suicide experiences questionnaire, along with a suicide Stroop and a suicide-related attention disengagement task, which I won't talk about today, and the SIQ Junior, a measure of suicide ideation, SCARED, which measures anxiety, and the PHQA, which measures depressive symptoms, and we followed them up at 3 and 12 months. We had a diverse sample, average age 15, primarily female, primarily Hispanic, Latina, primarily identified as queer, and we had some gender diversity in the sample. About 2/3 presented with their clinical event or signal event being suicide ideation, and about 1/3 with a suicide attempt. And about 2/3 were classified at baseline as having brief ideation, and a smaller subsample as intermittent and persistent ideation. So with that first hypothesis about whether persistent ideation would be associated with a greater attention fixation to suicide, using the AFSEC questionnaire, we found that that was the case, but for both intermittent and persistent ideation, we're associated with higher attention fixation to suicide. But when we used the suicide Stroop and a modified attention disengagement task, we found no differences. And then just looking at time to an attempt, about 21% of those with brief ideation attempted by 12 months, about 1/3 of those with intermittent, and about 47% of those with persistent ideation attempted at follow-up. And persistent ideators on average attempted within about a month for those who did attempt. So about 27% of our sample made a suicide attempt at follow-up. Within about 3 months, intermittent within about 2 months, and then brief within about 5 months. And looking at a survival analysis, when we adjusted for other covariates that we found at baseline to be associated with the suicide ideation subtypes, so like depression, SIQ Junior, attention fixation, suicide attempt history, gender identity, and race. Incidentally, we found that there was an overrepresentation of Black youth among those who had persistent suicide ideation, which is why we adjusted for ethno-racial classification. So we found that besides race, it was persistent ideation that was associated with over 3 times higher risk or hazard of making a suicide attempt for every subsequent month of the study compared to brief ideation. And if we got rid of the non-significant covariates, these are the variables in our final model. So it's 3.6, and then there's a trend for intermittent ideators to also show greater risk and shorter time to attempt. And just looking at it differently with a hazard curve, as you can see here, the cumulative risk for persistent ideation by 12 months approaches 80%, cumulative probability of attempting, versus brief, which is about 20%. And I made a joke earlier that when I showed my husband these results, I'm like, look at this graph, look how pretty it is. Look how distinct that they are. He's like, okay, so what does this show? Right? It's showing that the more they think about it, the more likely they are to attempt. Isn't that, like, what's earth-shattering about that? Wouldn't that be what you would expect? Like, next, are you going to study that water is wet? Well, the reason this is important is because we don't assess this. And if you want to try it out, right, those of you who are clinicians, you can do this. You can ask teens to tell you how often in the past 30 days they've thought about killing themselves and classify them into brief, intermittent, and persistent subtypes, right? It's like, I've presented preliminary versions of this before, and I've gotten these weird, like, that seems simple, right? Because we're spending we're spending millions and millions of dollars on generating computer algorithms and using all of these devices to monitor, to improve risk prediction, but this does it too. This seems to do it too. So, and we're not doing this. We're not assessing form of ideation in our clinical practice. So, form of suicide ideation matters, and it's possible that that some treatments may need to focus on disengagement from suicide ideation. So it has implications for thinking about different phenotypes, different subtypes, and how one might treat them. So those with brief ideation, we may need to focus on addressing the circumstances or the precipitants, whereas those with persistent ideation, that may not be the thing that needs to be focused on. So next steps in our research are to examine mechanisms that differentiate suicide ideation subtypes. So we just completed a study, and we're doing follow-up for a study with Dr. Tracy Dennis using EEG to look at differences in attention, engagement, and disengagement. If we can distinguish the suicide ideation subtypes, looking at differences in sleep, using EMA and actigraphy. We just completed an EMA actigraphy or daily diary study, an actigraphy study, to look at differences in these subtypes and what teens are reporting, to see if we can validate what they're reporting at baseline, right? Because if you're in a low resource setting where you're just going to see a teen once and you may never see them again, it's an important triage decision to make that, based on their risk level, based on their suicide ideation subtypes. So if you're only seeing them this one time, knowing whether this one clinical assessment is predictive of what their ideation might look like is important. And then we also want to start integrating consideration of suicide ideation subtypes into our assessments to adapt it to Spanish-speaking teens. And in collaboration with Dr. Lauren Gulbas, a study that's really I'm excited about. We just got a grant, an NIMH grant for, with Lauren Gulbas at UT Austin and Ana Ortin Peralta at Yeshiva and Einstein. Anna is an expert on preteen suicide, and we're looking at these suicide ideation subtypes in children. And in collaboration, Jesse Finkelstein, who I think is affiliated here, is helping us with some visual drawings. We've taken drawings that kids have made of the content of their ideation, and he's made visual depictions that we are trying to use to improve our assessments. And we've simplified our interview. We're using body mapping, which Lauren has adapted for use with suicide risk assessment. So it's a more visual way of trying to get at warning signs and assess suicide ideation risk. And then also, Erica Rodriguez has been doing some qualitative analyses, looking at different, what we call pathways of suicide risk. So imminent risk pathways. And she's looking at what we classify as more episodic pathways, which are the teens who have precipitated a suicidal episode, and chronic risk pathways, which are teens with a more maybe persistent ideation, more early onset of ideation or attempts, more past attempts, different kind of risk factors or precipitants, and trying to integrate that with our qualitative or quantitative approach to subtyping ideation to try to improve assessment. And then we also have folks who've looked at cognitive mechanisms using reaction time-based tasks. So Beverly Rosario Williams has looked at construct accessibility and attention engagement and disengagement with young adults. And so if you're interested in tasks that you might be able to use in that way, she has a paper in Journal of Psychopathology and Clinical Science and a recently published paper on Journal of Mood and Anxiety Disorders that found that if you induced a mood, it has an impact on suicide-related attention disengagement. And Alan Schick, who's a postdoc, former lab member who's at University of Rochester Medical Center, is looking at comparing lower and higher order measures of suicide-related cognitive biases and predicting risk of future ideation severity and attempts. Okay, so just some concluding thoughts. So a barrier in assessing risk and developing interventions to prevent youth suicide has been a limited understanding of suicide ideation itself. And so our research suggests that persistence of thought, so how people think about suicide, merits attention in not only understanding the cognitions, the hopelessness-related cognitions that give rise to suicide ideation, but also in addressing how persistent suicide ideation may provide information about short-term risk of suicide attempts and may suggest a way of modifying the cognitions that give rise to suicide ideation and attempts. I'd like to give a thanks to my lab. This is not everyone. We're a happy lab, and we're a very collegial, and I hope people are happy in the lab. One of the joys of working at a public institution is just the diversity and the life experiences of the students that come into my lab. They are often representative of the communities that we study in ways that at high resource universities you don't find. So please, thank you to those who have been part of this research. My collaborators, Dr. Wasim at Lincoln Hospital, Dr. Baroni at Bellevue, new collaborators, Ana Ortin Peralta and others. And a special thanks to David Schaffer, without whom I never would have done suicide research funding. And that's all I have.